But thank you guys for joining us today. I'm pretty excited to have this installment of the Ultrasound lecture series. We've been doing in our fellowship, we've been doing kind of the trauma resus block right now. And so this is going to be kind of in a part of that trauma resus block where we actually talk about the FAST exam. And so I posted a video this week about the basic fasting back in archives and posted that up. For the basic fast, we've certainly been kind of going over that. But today I want to talk a little about the FAST exam from a unique perspective, right? I want to take some cases that we've had over the years and really kind of dive into those and look at some kind of nuances in the FAST and things that kind of make the FAST, or things that aren't maybe quite as straightforward with the FAST exam, at least in the traditional, here's your 4 quadrants. So with that being said, let's dive right on in and talk about the FAST exam. And I couldn't come up with a better title. I apologize. It is what it is. So if you guys come up with a better title, great. But anyway, the FAST exam, some unique cases. For the purposes of the CME portion of this, for those who are attending on the Zoom, there's no disclosures to make as of right now. So basically, let's talk a little about trauma, right? So we've been kind of in that trauma, like I said, the trauma resus mode. And we're going to talk about the FAST exam, and we're going to kind of draw it all together with these unique cases and kind of pull out and tease out some of the unique things that you can see when you do the FAST exam. So this is kind of what we're typically accustomed to with a nice trauma resuscitation. And it basically just bring this up to say, hey, look, there is this trimodal distribution of mortality in trauma, right? We've seen this article or this picture before. We've seen it, whether it be in ATLS or in other trauma presentations, that patients who are traumatized, who end up dying, right, die in one of 3 phases, either immediately on the scene, right, so, and all of our EMS colleagues who are with us today, can attest to the fact that there's a lot of patients who have injuries that are sustained that cause them to die on the scene. We're talking about massive head injury, massive exsanguination, aortic or great vessel injuries, things like that are it's just not salvageable in these patients, right? They're just so significantly injured. Then there's that peak kind of in the minutes to hours, right? That 30% peak right in the middle. And these are the people that are injured, right? That make it to our emergency departments that need acute intervention, right? We could name off a couple of things like tension pneumos or pericardial tamponade, significant hemorrhage into the belly, things like that, that need some intervention, that without it, will certainly, have an untoward outcome. But with, some really timely intervention could potentially do well, right? And then there's that final peak, that last 20% or so, who die hours to days later, right? And so these certainly are sick patients, right? But they're the patients that probably are going to die up in the ICU or in the OR, that we don't have a lot of control over in the ED, right? Now they may be super sick, and we can do some things on the front end that kind of help mitigate some of those risks, but we're talking about the patients who die of sepsis or complications of their surgery or things like that, that we don't really have a lot of control over. So what we're going to really focus in on is kind of this 30%, right? And this is where the FAST exam comes in, kind of helps us identify where is this group of people that we can intervene upon, that we can identify things early so that we can basically shift that mortality curve down as we try to catch these things. I think I ran across something recently. We were talking about, one of the benefits of ultrasound is just finding stuff and differentiating things early. And it allows us to kind of get a head start on the management before the patient kind of decompensates further, and we could, ordinarily figure it out without ultrasound. So that's one of the benefits there. But this is kind of the cohort that we're gonna focus in on. Now, as we get going here, I want to do just kind of a brief recap of the FAST exam. Some people may not have seen previous videos or been previous lectures talking about the FAST exam. I know we all know it, but just kind of want to do a brief summary of the basic FAST, and then we'll kind of go into some of these new cases. So remember, the FAST exam is best suited as a screening tool to look for a couple things, right? And by a couple things, I mean 4. So a couple. We're looking at hemoperitoneum, or looking for hemoperitoneum, hemopericardium, right? That's a traditional fast. And then it was expanded to be the E-fast, looking for hemothorax and pneumothorax, right? So these are really the 4 things we're looking for. And if we kind of keep this in mind, it's going to keep us out of a lot of trouble as we try to apply the FAST exam in our patients and interpret that data. And if we start deviating from this, right, if we start looking for things other than this, then we start getting ourselves into trouble and start losing some points on the sensitivity of the FAST exam, and we start losing kind of the ability for it to be helpful for us, right? So keep in mind, these are the 4 things we're looking for: hemoperitoneum, hemopericardium, hemothorax, pneumothorax, right? And there's assumption that kind of underlies all this, right? And the assumption is that a significant traumatic injury is going to be associated with injuries that have free fluid or free air in the context of like a pneumothorax, right? And we know that's not always the case, right? You see significantly injured people who have injuries that don't present with free fluid or free air, right? Think about all the patients who have like a mesenteric hematoma or something like that, or who have a head bleed, right, for that matter, or have like a femur fracture with a massive exsanguination in the thigh. Like none of these are going to be necessarily associated with free fluid in the places that we see that we just talked about. So we have to kind of remember this assumption so that when we apply the FAST exam to our patients, we don't get ourselves in trouble. And so I think this study is kind of illustrative, talking about the sensitivity and specificities of FAST exam. Like if you talk to us sonophiles, we're going to say, look, the FAST exam is the best thing since sliced bread, and I don't care what anyone else says about it. It's the best test you're going to get, bar none. Forget the CT, fast them, right? So, I mean, okay, fine, it's a little hyperbolic, but the people who are into ultrasound really kind of look at the literature that says it's a high sensitivity. And some studies will say like 85 to 90 some odd % with high specificities. But then you'll have the naysayers and the skeptics say, but what about studies like this? Or there's another one I have that shows the sensitivity down in the 30% range. And here in the sensitivities in the 79% range. And the key is when you look at the studies, the methods matter, right? What are you looking at and what are you comparing to? So if you're comparing an ultrasound to anything with free fluid, it performs quite well. Ultrasound versus, like CT for looking at all intra-abdominal injuries is not going to perform terribly well, right? And so that's when we lose our sensitivity points. Now, specificity, here maintains itself pretty well. We're looking at 99%. So if you see an injury, it's probably there. But again, remember, ultrasound is not particularly suited, at least in the context we're applying it, to look for solid organ injuries or other like mesenteric or, hollow viscous type injuries. We're looking for things that have free fluid or free air. So hemopericardium, hemoperitoneum, hemothorax, and pneumothorax, just kind of getting back to that. So if we think about it in that context, right, the FAST exam is a screening tool for the thoracic, pericardial, and abdominal space to look for fluid or look for air. And I like to think about it like if you have an unstable patient, the traditional dogma is like hypotensive trauma patient needs blood, right? Now, there are nuances and there are caveats, right? But they're probably bleeding from somewhere. Like hemorrhage is the major cause of death and trauma, right? And so where's the blood? And I like to think about it. It's in the head, it's in the chest, it's around the heart, it's in the belly, the retroperitoneum, the pelvis, the thighs, or the floor, right? Those are the main places that you're going to put blood in a trauma patient. And my ultrasound can tell you a good 3 to 4 out of 5 of those places that you're going to put the blood, right? And so it's a screening tool to look for free fluid or pneumothorax in kind of these areas, right? So with that being said, there are 4 basic windows. We're just going to remind ourselves really quickly what those 4 windows are. Here's the right upper quadrant, right? And so you can see the liver, kind of the main landmark of the right upper quadrant, and the kidney, right? And so I like to talk about landmarks when I talk about, teaching ultrasound. You think about it, when you get into the airplane, you're going on vacation somewhere. So you climb in the airplane, you take off at the airport, you're trying to find your house, right? Because it's just kind of cool. Like who doesn't want to find their house and look at it from, 10,000 feet as you're taking off? And so you do that by triangulating. You look for landmarks, so when we take off at Hopkins, okay, where's the lake, right? That's the big one. It's a big landmark. You can't miss it, right? If you're on the right side of the plane, you can see that. Okay, there's the lake, right? Where's the city? Okay, there's the city. Now, where's my house? If I know where the lake and I know where the city is, I can triangulate to find my house. And the same thing with ultrasound. Where's the liver? Let's find the liver. It's really hard to miss unless they have like massive free air or something. But let's find the liver. Okay, now let's go kind of retroperitoneal until we find the kidney. Boom, I found the kidney. Good. I can take a deep breath. I got my landmarks. Now let's start looking around, right? And so we have the liver, the kidney. That space between the two is Morrison's pouch. It's a potential space where fluid can collect. But we also want to identify the diaphragm just on the superior or the cephalad aspect of the liver, right? Because just above that is going to be the pleural space, right? And so we're going to put fluid in that costophrenic angle if there's a hemothorax, right? So we want to really find those areas. And we're going to dive back into this later. You really want to look for those 3 areas in the right upper quadrant, right? That costophrenic angle, the Morrison's pouch and that caudal tip of the liver. Kind of those are different major points that fluid can collect. And so here's an example of a teeny tiny bit of free fluid between Morrison's pouch and the liver, right, on the left. And if you look at that caudal tip, you can see just a little wedge of fluid kind of at the caudal tip of the liver and the caudal tip of the kidney there. So that's the right upper quadrant. The left upper quadrant is very, very similar. The spleen, though, tends to be a little smaller. So that means the structures tend to be a little bit more posterior and a little bit more cephalad. So I say knuckles to the bed towards the head as you're trying to find that space with the ultrasound. But you're going to look for basically the same thing. Look for the spleen, look for the kidney, find that splenorenal fossa, right? Look for the diaphragm, because fluid can collect between the diaphragm and the spleen. And then you look for that pleural space, right? That costophrenic angle just above the diaphragm of the spleen. And then for, here's an example of just kind of a left upper quadrant view. You can see that thin kind of crescentic shape of the spleen with the diaphragm above it and just a little bit of fluid kind of around the tip of the spleen in both the left and the right image there. For the pericardial window, again, we're going to probably go in the subcostal space, although you can do a parasternal long if that would be better based on the patient's habitus, your skills and abilities with that particular patient. But we're looking for fluid collecting in the dependent area, right? So kind of deep down in the screen, kind of posterior aspect in that pericardial space. And so the LV-RV that's labeled there, that bright white line is going to be the pericardial space. That's a potential space until you put fluid in it, and that's the place where the fluid would collect. And so here's an example of collected fluid in that pericardial space. And you see there's a thin layer on top, right? But there's that bigger area in the dependent aspect of that, that pericardial sac. And that's really what we're looking for right there. And the final window for the traditional FAST exam is the pelvic window, right? The bladder window. There's multiple ways of doing this. I particularly like the sagittal orientation because it allows me to see into the abdomen and it allows me to see kind of down in the pelvis and differentiate the two. And so I don't have to wonder if I'm looking too far down into the pelvis or I'm looking up into the abdomen. I can really see both and kind of sweep from side to side. Look for the iliac crest, kind of that bone shadow as you look from far left, far right, and kind of sweep that whole suprapubic area and see if there's fluid that collects kind of behind the bladder in the retrovesicular space. And so here's an example of fluid, outside the bladder. So you see the contained fluid in the bladder, that kind of water balloon that's sitting right in the middle of the screen, and then some fluid outside the bladder. And these both are examples in male patients. And if you were to have a female patient, you'd basically just insert a uterus kind of in that retrovesicular space and look for fluid kind of anterior and posterior to that uterus as well. So that's the traditional windows. And then just to kind of round this out, the thorax windows, we talked about looking at the subphrenic space or the costophrenic angles where fluid can collect in the pleural space. But if you look anteriorly where air is going to be, right, the least gravity dependent area, you want to look with linear probe, curvilinear, whatever probe you want, to see if there's lung sliding, right? You look for the rib pleural line. So on the right image, you see kind of those dark shadows kind of bookending either side of the right side of that image. And that bright white, that top bright white line, that's the pleural line. And we look for shimmering and sliding along that line. And then we can put M mode on it and get that sandy beach appearance to rule out the pneumothorax at that point, right? If you want to rule out pneumothorax entirely, you got to scan all the way up and down the anterior chest. But if you have a crumping patient who you're worried about, like a hemodynamic pneumothorax, one point should tell you that, understanding that you'll miss small little pneumos if you don't do the whole thing. So that's kind of the FAST in a nutshell, kind of recapping that one, kind of refreshing our memory. So with that said, let's dive into patients here and kind of look at some of the things that may nuance the exam. So that would make it not kind of the traditional exam that we've seen. So all these cases, obviously the images are from people that we've seen over the course of the years, but the stem here is going to be completely made up. And so to any extent that they are reflective of patients, it's coincidental and not actual, to the profound degree. Anyway, long way of saying we've tweaked things to protect the HIPAA anonymity of our patients. But anyway, imagine yourself seeing an auto versus pedestrian, right? So this is a unfortunate patient who got hit by a car. They got brought into the emergency department. Their vitals look okay. I guess their sats are a little bit on the low side, but they have a blood pressure that, we don't know much about the patient's age, but it's 100/65. So our map is greater than 65. So at least we're perfusing things. We don't know what they're used to. So we have to kind of interpret that with a little bit of a grain of salt. Heart rate 95, Respir's 18, SAT's a little bit on the low side. Okay, that's something that maybe need to be addressed. But we want to do the FAST exam, right? And so we do this FAST exam and we see the right upper quadrant here in both images. So you can see kind of more of the liver kind of in the right-hand image, a little bit more of the kidney in the left-hand image. And I don't know, is there a thin stripe of fluid? It's kind of an equivocal exam, right? Is there something we don't really know? Like the trauma surgeon's asking for a call. You're kind of new to doing this. Do you really want to stick your neck out and be wrong? I don't know. Maybe we'll see. So we do the left upper quadrant. So here is the liver or the spleen. You can see the diaphragm very, very clearly. We don't really see the kidney quite as well, but there's certainly no obvious free fluid. So I don't know. Negative, equivocal. What do we think? Maybe we'll see. If you go back to the right upper quadrant, though, to kind of interrogate that one a little bit further and look down, we'll see this little wedge of fluid. And okay, fine. We showed this image a little bit ago, and so we know it's positive, right? But this one here has fluid that's predominantly seen at the caudal tip of the liver, right? And the inferior pole of the kidney. And I brought this up because this illustrates a really important point with the FAST exam, right? There's a study that was performed. This one looks like, I think it was 2016, 2017 era, out of California, that basically was looking at when you do the FAST exam, what is the most commonly positive place that you see, right? If you're just going to guess, hey, I have a patient in front of me, they're hemodynamically stable, pick a spot. Where's it most likely going to be positive? Where are we going to most likely see the fluid, right? That was their study objective. They wanted to identify this, right? And I think it's helpful because if we really identify what's the most likely place that we're going to see the fluid, we can really focus in on that area. And let's even turn myself off there. So there's a QR code. If you guys want to snap that to get the reference, so you can kind of dig into this yourself. But this is the question: where is free fluid most commonly seen on the FAST exam, right? So they divided things up. They took the right upper quadrant, the left upper quadrant, the pelvic window, and kind of defined areas, right? So here in the right upper quadrant, they said R1, R2, R3 are three different spaces. So R1 is kind of that subphrenic area. R2 is the traditional Morrison's pouch, right? So if you open up a textbooks about the FAST exam, that's R2, right? And R3 is going to be at the caudal tip of the liver, right? And here's some examples. You can see, like, especially on the right, R3 with some free fluid, R2 and R1 are negative, right? So that's at the right side. They did the same thing with the left side, okay? The subphrenic space in the left, and then the splenorenal space between the spleen and the kidney, and then the caudal tip of the spleen for L3, so L1, 2, 3. And then for the bladder, they did SP1, SP2. So SP1 were kind of off in the wings, SP2, SP3 were kind of anterior, posterior to posterior to the bladder, but like anterior, posterior to the uterus, right? So that's what we got: R1, 2, 3, L1, 2, 3, SP1 and 2 and 3. And so they basically said, okay, we're going to identify our FAST exam patients, right? So we'll do how many FAST exams we did, ran them through their inclusion criteria, threw out all the negatives, and they were left with 48 positive studies. And they said, okay, fine. Where in these studies was fluid seen, right? And so they basically identified the right upper quadrant. They had 32 patients with fluid, left upper quadrant, 17 patients with fluid, and the suprapubic space, 23 patients with fluid, right? And then they further subdivided it out, and they found that the most commonly positive place was R3, right? Which kind of makes sense, kind of going back to this study that we'd seen. The caudal tip of the liver is the most commonly seen place where you have fluid. And so you can think about it like this: if you have an injury, right, and the patient's walking around, right, they're going to get fluid to collect in their pelvis, right? As you lay them supine, that fluid is going to migrate up the pericardial gutters and then into Morrison's pouch. And so Morrison's pouch, while one of the most gravity dependent areas in the belly, the fluid has to get there somewhere unless it's coming from Morrison's pouch, right? And so it's going to come from somewhere else, enter into Morrison's pouch via that caudal tip of the liver. And so it's not uncommon to see it collect at that caudal tip of the liver as it's dumping itself into Morrison's pouch. So it makes sense, right? And my good friend Mike Pratt's over at Ohio State did a Ultrasound gel podcast looking at the same type of thing, looking at this study, and they basically, were showing this most commonly positive place. 30 out of 32 patients with fluid in the right upper quadrant had it at the caudal tip of the the liver, right? So that brings us to the first teaching point. Carefully look at the pericolic gutter, right? This is going to be the critical place when you're talking about fluid, because this whole idea of fluid in your belly, it's not a static thing, right? You're injured. The injuries cause problems, and that those problems dynamically evolve over time. And so we'd expect to have some dynamic changes to our ultrasound findings as these patients are kind of progressing through their state of injury. So look at the pericolic gutter, right? This is the most commonly positive place where we see fluid in the belly, right? Make sense? Got that one? So let's move on with that one to our next case. So this is a patient who fell 20 feet and landed on their left side, right? And it looks like I apparently copied and pasted the vitals from patient to patient. So that's why I said it kind of loosely reflects reality, but it's supposed to kind of give us a little flavor for what the exam stem might be, or the patient presentation might be for the exams that we see. And so as we kind of dive into this one, think 20 feet, fall on the left side, kind of some marginal vital signs, and we'll dive into that one. And we see first this image, right? So we have the right upper quadrant, right? We got some fluid at the caudal tip of the liver. We have some fluid kind of pouring into Morrison's pouch there. And then kind of look at the left upper quadrant, right? We have on the left image, we have the spleen, right? And on the kidney. So you kind of see that splenorenal recess. Don't really see a ton there, maybe something, I don't know. In the right image, we see the spleen and the diaphragm that's kind of above it, that bright white line, but there's something interposed between the diaphragm and the spleen, right? There's something dark there. So that's kind of concerning. So we'll kind of focus in on that. And that, in this context, is basically, since the patient fell on their left side, they have injuries on the left side, that's going to be consistent with free fluid around the patient's spleen, right? And so unlike the right side, where R3 was the most commonly seen place, the subphrenic space in the left side is one of the most common places to see fluid in the left upper quadrant, right? And so that brings us to this study, right? This is a study we did. I'll turn myself off so you can see the QR code. This is a study we talked about a couple months ago in the Ultrasound Fellows Journal Club, and I thought it was really, really interesting to see where novice trainees, right, where residents and fellows look when they're doing the FAST exam, right? Because we can see, hey, look, we know where we're supposed to see stuff, right? Where are people looking when they do this study? Are they looking at all the right places? And if not, where are those places they're not looking, so that we can then go back and circle back and kind of say, hey, look, we should probably have you look here, right? So that was really an interesting study. And so what they identified is some standardized zones, kind of like what we saw in the previous study, like R123, L123, things like that. They identified these standardized zones, and then they said, okay, we're going to put on these really cool glasses, right? I forget what glasses they were. There's basically some gaze detection glasses. And you're going to do this exam, right? And we're going to see where you're looking, right? We're going to see if you're hitting all the places we want you to hit, because we have this superpower where we can actually see where you're looking. So you can't just say, oh, yeah, of course I look there. Of course I look there. We can actually know now as the educators, right? So they put these gaze fixation glasses on. They looked at where the studies looked, and they came up with this data right here. And this is kind of a messy table. And I know it's a lot to kind of take in, having not kind of digested this study before. But what's interesting is most trainees did a great job looking at all the places. So if we kind of identify R123, L123, SP1, SP23 that we saw in the previous study, most of them hit that, right? So it's not really, the nomenclature isn't quite the same here. They actually spell it out in terms of words. But you can see, like at the top line, the right upper quadrant diaphragm, right? Go into the middle column, the number of viewed areas percentage, and 92% of people are looking under the diaphragm of the right upper quadrant, right? If you go down to the caudal tip, so the third one down, right upper quadrant, liver tip, and inferior kidney, 92% of people are hitting that area. But what's interesting is the one place that gets missed, right, is that left upper quadrant diaphragm. 79% of people who wore these super cool gaze fixation glasses looked at the left upper quadrant area, which means a substantial portion of patients, 21% or of trainees, I guess, didn't look there, right? And they looked in other places. And I think it's kind of, interesting that they didn't look here, because like I said earlier, this is one of the common places that fluid is seen in the left upper quadrant. And so we go back here to our case, right? This is exactly where a patient in our case had their fluid, right? They have it between that spleen in that diaphragm. And it has to do with kind of the peritoneal reflections inside the abdomen that make it really, really hard for fluid to kind of migrate kind of through all those reflections and into that splenorenal space. And it's really easy to shoot up that gutter and right around the top of that spleen, right? So as we kind of do our studies, we go to the bedside, keep this case in mind, or this study in mind. This is a great place for us to look, right? As we do our left upper quadrant, make sure you're looking at the spleen and look at the diaphragm, what's between the two, as well as look at the spleen and the kidney and what's between those two, right? And here's another example, just kind of a freebie for you. Left upper quadrant, patient has injuries on the left side. We see the spleen quite nicely, but what else is there, right? This patient also has a subcapsular hematoma. So there's like almost like a secondary spleen on top of the patient's spleen. If you look kind of going down from the wedge of the pie, kind of going down, you'll see the skin and soft tissue, the bright line of the peritoneum there. And then you see that first wedge and then the second wedge, which is the spleen. So this patient has a subcapsular hematoma. And if you don't intentionally look there, you might miss these things, right? And so it's really, really important to scrutinize that left upper quadrant view. Which brings us to our teaching point, right? Be careful to scrutinize the subphrenic space in the left upper quadrant, right? So that brings us to our third case, right? And this is another auto versus pedestrian. So some other poor person walking around the streets of Cleveland gets hit by another car. And this time they're hypotensive, right? Didn't copy paste the vitals this time, right? This time they're hypotensive, 80/30, right? 110 is their heart rate. So it's not good in the setting of trauma. This is blood somewhere. We got to find it, right? But from a respiratory standpoint, they're doing half decent, right? Okay, maybe they're a little hyperventilating. I don't know. Is that the adrenaline? Is that some compensatory mechanism? I don't know. Whatever. But they're statting fine, right? The big issue is they're hypotensive, right? In the context of their trauma. So just kind of a quick, buzz through. So this patient here, the left upper window is going to be subcostal. We don't see any free fluid around the heart. Right upper image there is going to be this right upper quadrant, right? So you see the liver. We can see a little bit of the diaphragm, kind of the bottom side of that image. We can definitely see the kidney, so the Morrison's pouch space. Maybe not quite so much of the caudal tip as we'd like to see. We definitely would want to take some more images when we're doing it in real time, but we've already covered that case, so it can't be that today, right? So the right upper quadrant seems ostensibly normal. Left upper quadrant, kind of a little bit fuzzy, right? But you can kind of make out a little bit of a spleen in there, a little bit of a diaphragm. And so I don't see a lot of free fluid. That's going to be, okay, maybe not the best window. It's not going to be the one that's going to make it in the next iteration of the textbook, but certainly enough to say, okay, we're good. And then the pelvic window, really not great at all. There's, just a lot of air shadowing, but I don't see any obvious free fluid. So we may have to kind of lean towards equivocal if we can't get some better images, right? But what I really want to see, since they're hypotensive, I really want to go up to the chest and make sure there's nothing going on there, right? So this is the left side of the chest, right? So here's the left lung, and we see some nice sandy beach, indicating that there's going to be no pneumothorax in that space. And let's go to the right-hand side, right? What do we see here? Are we looking for, do we see any signs of like a pneumo, any signs of, anything? I mean, it's really hard to see anything here, right? It's just a whole bunch of just, honestly, it looks like a bad TV, connection from when I was growing up. It's just all static. And I remember vividly doing this case, like I can't see anything. I'm scanning up and down the chest. Like I need to find a landmark. I need to find a rib, right? Because the rib is going to tell me where the pleural line is. And I have no clue in this image where that pleural line is. Like I cannot find a rib. And interestingly enough, you kind of feel around the chest, you'll feel like some Rice Krispies, which now that gives it away, right? And this patient ended up having a massive amount of subcutaneous emphysema, right? Which really explains nicely why we couldn't see the rib, because there was air between the rib and the probe, right? And so if we got air between the rib and the probe, all we're going to see is just like that air signature and the dirty shadowing of air that's just going to block everything, right? And so this patient had a massive subcutaneous emphysema, but they also had underneath all of that a pneumothorax, right? And so that was our concern, right? Do they have a pneumo? Do we need to do anything about that? Is that what's causing their instability, right? Which brings up kind of this idea of, pneumothorax and kind of what tips us over kind of to be worrying about these, and so this was a study that was performed. This was performed a while ago, but if you notice, one of our esteemed Dr. Bullinger is on the study here. But basically, what they're looking for is risk factors for occult pneumothorax in victims of major trauma, right? So they're trying to find patients who have a pneumo, right? And I'll turn myself off so you can get the QR code again. They have a pneumo, right? What are risk factors for identifying that one? Like before you even get to any imaging, what are some risk factors? And one of the major risk factors, look at that very first line, subcutaneous emphysema, right? So if they got subcutaneous emphysema, the sensitivity is horrible, right? You can't rule out a pneumo based on lack of subcutaneous emphysema. But look at the specificity, right? 98% specificity. So if you got subcutaneous emphysema that correlates with your trauma, right? There's probably a pneumo underlying all that. So when you see the study that we just saw, right? When you see that ultrasound that has just massive air and nothing else, and you feel the Rice Krispies underneath your probe, there's probably a pneumo there, and you probably need to go figuring that out with some other imaging modality to confirm location, size, etc. Okay. Interestingly, just kind of tie in a few other things regarding ultrasound, because we have to just kind of extol the virtues of ultrasound. So this was basically a meta-analysis of ultrasound versus chest X-ray looking for pneumothorax, right? And so it found that the sensitivity of ultrasound was about 98% for pneumo, with specificity close to 100%, right? So this is multiple studies kind of combining them all together, understand all the details about, or all the issues with meta-analyses. But, hey, it is what it is, right? They're finding a really good sensitivity for ultrasound for pneumo. So if you actually see rib pleural line and see lung sliding right there's no pneumo there, right? And if you can go scan up and down that chest, all the way from clavicle down to the diaphragm, and say, I have lung sliding in every place that's gravity dependent, I probably don't have a pneumo, right? And on the flip side, if you have lack of lung sliding, you're pretty much done, right? There's a few other reasons why you can have lack of lung sliding. Apnea, probably not going to be best diagnosed with ultrasound, but that's one of them. A previous pleurodesis, right? That will cause lack of lung sliding, or some form of adhesions will cause lack of lung sliding. Right main stem intubation, if you're looking on the left, those are various different things. So it may kind of take a few, points off the specificity side, but really, if you see lung sliding, there's no pneumo at that spot. And if you see I said that backwards. If you see lung sliding, there's no pneumo at that spot. And if you don't see lung sliding, it's probably a pneumo, right? Chest X-ray didn't perform terribly well, right? The sensitivity for chest X-ray was about 50 to 70%. Now, interestingly, the chest X-ray was 100% specific for pneumo. But again, we're splitting hairs on the specificity side. So just know that kind of going in, if you have a trauma patient, you lay them down supine, you shoot an X-ray, and it says no pneumo, you have to read that with a grain of salt. It could be as low as a coin flip, right? Now the further question, because we're all about kind of taking our ultrasound to the next level, right? You do the textbook style ultrasound, but we want to take it to the next level to be just the best that we can be, right? And provide the best service we can for our patients. So the next question is, okay, fine. You're telling me there's a pneumo. Wonderful. Not all pneumos get treated the same way, right? I don't stick a tube in all the people that have a little bit of a pneumo, because if it's just a small one, just put them on some O's, watch them for a little bit, repeat a chest X-ray, see what's going on, right? If it's a massive one, you absolutely. And there's a little bit of gray spot on the kind of that space in between. So can we use ultrasound to help us decide which ones get a chest tube, right? And so this study basically was looking at a quantification of pneumothorax size using ultrasound, right? And what they found is that basically ultrasound compared nicely with chest X-ray and CT to evaluate the lung size, the size of the pneumothorax. And there was another study. I don't have that other study here, but there's another study that I've run across over the years that basically said, okay, fine, we're going to do an ultrasound and mark off where the lung sliding stops, right? Where you have that lung point, send them through the scanner and see if it correlates. And lo and behold, if you kind of manually mark off, either in your head, with this time on patients, where the pneumo stops and CT them, they do correlate, right? And it makes sense, right? The pathology is being just visualized with two different imaging modalities. And so we can really use ultrasound to quantify. So once you found the pneumo with your scan, you're not done, right? Now you need to move up and down the chest and move laterally to see how big this thing is, to identify, is this something I need to intervene upon here? Or can I defer that, for further imaging to confirm that this thing is really, really small? that make sense? So the teaching points on this case is basically be concerned about a pneumothorax when you see sub-Q emphysema in the setting of trauma, right? That's something that's major. And probably, we could think about this one a little bit, but probably in the setting of medical patients as well, if they've got sub-Q emphysema, this probably should be on your list of concerns too, right? But specifically in trauma, because that's what we're talking about today, if you see sub-Q emphysema, there's a high specificity for an occult pneumo, so be worried about pneumo there. And then when you do the scan and you identify the pneumo, don't stop, right? Keep going and quantify how big that thing is, at least in your head, so you can decide, what the next step is. And at least, if for nothing else, be kind of one step ahead of the game, so the patient decompensates, you're kind of aware of what's going on, but you can also kind of be one step ahead of the rest of your colleagues to really know kind of where things are headed with this patient, right? So our next case is—
Hey, Matt.
Yes.
I have a question.
Yes.
In regard to that sensitivities of the ultrasound and ruling out a pneumo, basically, what do you like to see from the static images we're putting in Epic, like medical legally? It's been one of my practices to just film ultrasound these like blunt young traumas with no belly pain, and then, rule out pneumo that way without scans. What zones do you want to see and labeling on your side?
So what I want to see is, for if you're stuck with a static image, which in our system we are right now in terms of what's documented in the record, I want to see an M mode, right? That shows me that lung sliding, that can show me that, I got lung sliding there. Ideally, I guess it kind of depends on the situation. Like, definitely on a supine patient, I want to see something anterior, right? And so when you're saving the images, I usually only save like one image per side to document that there's no pneumo there. But when I do it, I make sure I scan all the way from the clavicle. So I'll put the thing down, scoot up to the clavicle, and look at every single rib space from the clavicle, moving myself all the way down to when I lose lung, right? Which on the right, it's at the diaphragm. On the left, it's at the heart. And if I'm in the anterior lung spaces, right, in a supine patient, that's where air is going to collect. So I do that, and that's usually what I do, and then I'm done. I don't do like a whole bunch of like lateral stuff if I've got normal stuff on the anterior spaces. Does that make sense?
Yeah, that makes sense. And is that sensitivity the same for like a hemo too? Do you know? Or is it just
the hemos would have a different number. I don't have that number on the top of my head. But you would be looking at a different place, right? So you'd be looking
lateral.
Laterally, yeah. Basically doing the left and right upper quadrant windows and scooting yourself up, right?
Okay.
To look for pleural fluid. And my gut, and Dan Mersch, you can kind of chime in here if you have a number and a PubMed reference, but my gut is that ultrasound is going to perform pretty well, because ultrasound can definitely identify a small amount of fluid, like smaller amount of fluid than chest X-ray can, particularly in the supine patient. I think, to me, it makes sense.
Talking about hemothorax?
Yes, hemothorax.
Yeah, I know it's more sensitive than chest X-ray, but as far as a specific reference, give me a couple minutes.
Yeah, Dan, if you find one, just throw it up in the chat. But I think it's gonna follow kind of like the pneumo, like in a supine patient. A small amount of fluid is just gonna get lost on the chest X-ray, whereas in the ultrasound you'll see a small amount there.
Okay. Small amount, probably clinically insignificant. So, okay.
Well, that's up to you to.
Yeah, I mean, that's up to the patient picture. Yeah, but I'm just thinking for practice. Perfect. Thank you so much.
Yeah, no problem. Good question. All right. Any other questions before we move on? That was a great excursus there, Jen. All right. So our next case, we're going to dive into this one. So it's a motor vehicle accident with significant front end damage. Patient rolls into the emergency department, CPR in progress. When you ask medics, hey, when did you lose pulses? It's always, there's something that you guys in the EMS division are teaching them or putting in the textbooks. 100% of the time, they always lose pulses as we were rolling up. And I get it. The time window gets really compressed when you're kind of in a very stressful situation. So, when I ran EMS, remember there are times we call and report and like, yeah, our ETA is, oh, by the way, we're just backing in, you just kind of lose context of time a little bit, when things are going sideways. But anyway, this patient, MVA, front end damage, CPR in progress. Here is the ultrasound, right? So we see, this is basically a subcostal window, right? So we're looking and we see some movement, right? That's going to be the heart, but we see something inside the pericardial sac that's surrounding the heart. It's kind of echogenic, right? And so this is basically going to be massive amount of hemopericardium with clot, right? You can kind of almost see above that heart, that organized, it almost looks like jello that's kind of jiggling around inside that pericardial sac. So this patient lost pulses, still has a heartbeat. It's go time, right? This is the time for resuscitative thoracotomy. Let's get this thing open. Let's get that drained out and see what we can do, right? And so with that in mind, it brings up this study that was published back, I think it was 2015. Yep. Basically out of the folks, from the folks out of UC, or it's, I think it's UCLA or somewhere out in LA County, I think. So this is a bunch of trauma folks who basically said, can we use a FAST exam to predict outcomes for resuscitative thoracotomy, right? Because thoracotomy is, while wildly interesting and very dramatic, they don't really have a great survival rate. And because we're all really, really spun up and kind of working fast, there's a pretty good chance that someone's going to get hurt. Right. This certainly happens. You accidentally get cut, you accidentally get poked, something's going to happen. The last thing you want to do is, basically go to employee health afterwards and kind of have to deal with all the fallout of that. Right. So is there a way that we can identify which patients might do better and which patients won't, so that we could say, yeah, this isn't going to work. We're not even going to open the patient up versus, yeah, let's, full court press, we're going to do this thing, right? So what they identified is basically patients who received resuscitative thoracotomy, right? So in their cohort, they said 223 patients had a resuscitative thoracotomy, right? And they basically identified all the patients who had a previous FAST, right? They threw out all the patients who didn't have a FAST because that's not what we're studying the FAST and predicting resuscitative thoracotomy. So throw those out, right? So they have 187 patients who had a FAST and a resus thoracotomy. And they basically divided them up into survivors, organ donors, and people who passed away and said, okay, if the FAST was positive or negative, how does that predict the outcome? And so they defined a positive FAST as a beating heart or free fluid, right? And they defined a negative FAST as no beating heart or no free fluid. And so if you do kind of like that, the square table, like the 4x4 table, there's some ambiguity with the overlap, but just for all intents and purposes, for our purpose, FAST exam, if you see a beating heart or if you see fluid, that's positive. If you don't see that, it's negative, right? And so they determined that the vast majority of people obviously expired, and that if you had a negative FAST, the vast majority of those people did not do well, right? And so they subdivided it out into, in their table 4 and 5, with patients who had a heartbeat or no heartbeat, right? What was the sensitivity of FAST for predicting death? And is very, very sensitive, right? If you have no heartbeat, you're not going to survive, right? So, and this kind of falls into kind of the practice pattern that we see happen with the trauma service, right? They get in there, we have a potential injury to the chest, right? A GSW of the chest, whatever. We scan them, no heartbeat. Probably not going to make it, and they're going to probably call it, right? And the data here would certainly support that practice. So in table 5, they're talking about, okay, what about no heartbeat or no free fluid, right? Because, okay, so fine, you have some free fluid, but no heartbeat. Is it going to work? No heartbeat, no free fluid. Again, sensitivity very, 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 very high, predicting death essentially. So if you have, the takeaway from this one is if you have no fluid around your heart, right? Well, first of all, if there's no fluid around your heart, that's not going to be pericardial tamponade. Second of all, if you have no fluid or no heartbeat, this is a non-survivable injury from a pericardial standpoint, and resuscitative thoracotomy is probably not going to work. And so probably best not to attempt that, but it's best not to put all the people at risk for a procedure is really not going to have any impact on outcomes, right? And so this is what we see our trauma colleagues do. Look for the fluid, look for the heartbeat. Nothing, we're calling it, right? So teaching point on this one: for penetrating trauma to the chest, perform a thoracotomy if you have cardiac activity, right? That was in the case that we had. You could clearly see they had fluid. You could clearly see that they had cardiac activity. Open this thing up, and and there's a greater chance of survival in that context, right? So with that being said, as we kind of recap things here, we looked at 4 different cases that kind of showed some nuances to the FAST exam, but we kind of go back to the basics, right? The FAST exam is best suited as a screening tool for these 4 things, right? Hemopericardium, hemoperineum, inverted those 2, right? Hemothorax and pneumothorax, right? And if we keep this in context and look for those specific places that we've kind of identified over the course of this talk as potential trouble spots, I think we'll really take our exam from kind of a good to a great exam. And that's really the goal of what we're trying to do, is just be the best at what we can be, as you know, for our patients. So hopefully as we go to the bedside, whether it be today, tomorrow, next week, next month, this can be really, really helpful as we think through kind of how we do these things. So with that being said, we'll open up for questions here in just a sec, but I appreciate you guys joining us and being part of this lecture series. As always, we're putting up some really good material on our social media threads, either on Twitter, Instagram, or on YouTube. And this video will debut on YouTube next week once I get it mixed down and posted next Wednesday. So thank you guys for being here. Any questions kind of about what we talked about? Any comments? Dan, I see you're throwing up some references, which is great. But anything you guys want to jump in and say?